Good day everyone. Today we will look at a very important subject, nutrition for premature infants. Before we continue, we should understand what we mean by premature infants. As you all know, the development of a fetus can be monitored by the weeks of gestation, and they are categorized as preterm, term and postterm. A full-term infant is born between the 37th and 42nd week of gestation and weighs at least 2,500 grams. A preterm or premature infant, on the other hand, is born before the 37th week and weighs less than 2,500 grams. Nutrition requirement is the greatest in the last trimester, and deficiency can lead to premature birth and low birth weight. When an infant is born prematurely, it faces many metabolic, developmental and thermoregulatory issues. Some of these issues include inability to coordinate sucking, swallowing and breathing functions, small gastric capacity, immature liver and kidney systems, very low fat stores for energy and insulation, and inadequate lung surfactant. Thus, the premature infant becomes vulnerable to jaundice, hypoglycemia, respiratory distress syndrome, meconium aspiration pneumonitis, etc. Proper nutrition for the infant is crucial during this period. In normal pregnancy, there is an accelerated rate of in utero growth from around 29 weeks to 37 weeks. Premature infants born during this period of gestation need to imitate this rate of in utero growth and hence require appropriate energy, protein and other nutrients. This is because they have to grow very fast, but have immature digestive systems, low stores of fat and other nutrients, and a limited ability to excrete nutrients excesses and metabolic wastes while having to adjust to the external environment. Premature infants have an immature digestive system that can cause lower gastric acidity, absence of gastric pepsins, insufficiently developed enzymatic pathways for cysteine and tyrosine, very low lactase enzyme levels, low concentration of intestinal bile acid, and low amount of pancreatic lipase. Premature infants have to deal with other complications of growth as well, unlike term infants who double their weight in the first 6 months. Premature infants have to triple their weight, thus requiring more nutrient and energy-dense formula. Premature infants can be divided into 3 categories: low birth weight or LBW, which are infants weighing less than 2,500 grams, irrespective of the weeks of gestation. Very low birth weight or VLBW, infants weighing less than 1,500 grams. Extremely low birth weight or ELBW, infants weighing less than 1,000 grams. A formula for the feeding of preterm and VLBW infants must be purpose formulated in order to meet the established nutritional and feeding requirements of these infants. The best model for the growing preterm infant is the growing fetus of the same gestational age. The total protein content of a 26-week-old fetus weighing 1,000 grams must increase by about 5 times to reach the values observed in a term infant of 3,500 grams. LBW infants often do not require intravenous feeding after birth and should be commenced on gavage feeds before 2 hours of age. A volume of 60 to 90 ml per kg per day is commonly employed on the first day. Very low birth weight infants born before 34 weeks of gestation lack coordination of sucking, swallowing and breathing, and therefore need to be fed by nasogastric or orogastric gavage feeding, using a large syringe inserted into the end of the gavage tube. In LBW and VLBW infants, their very small stomach size restricts the volume of feeds that can be administered at any one time and therefore require greater frequency of feeding. This also means feeds need to be at a higher caloric density and also provide high protein intake. Yet, this must not be at the expense of a higher osmolality. Extremely low birth weight infants are fed by the method of total parenteral nutrition, or TPN. Unlike enteral nutrition, energy absorption during TPN is essentially complete. In TPN, an optimal supply of amino acids is crucial. If the pattern of amino acids is not well balanced, then the first limiting amino acid will compromise protein synthesis. However, parenterally fed preterm infants are at a risk of amino acid toxicity due to excessive intake, immaturity of degradative pathways, immaturity of kidney function for nitrogen excretion, lack of small intestinal metabolism, absence of first hepatic pass. Free introduction of nutritionally inconsequential amounts of enteral trophic feeding is vital to avoid gut atrophy. This is known as gut priming. Gut priming is early hypocaloric feeding where subnutritional quantities of milk enter the gastrointestinal tract as frequently as hourly feeds rather than contributing to daily nutrient requirements. Gut atrophy develops rapidly in preterm infants maintained on total parenteral feeding, possibly due to absence of agents in milk that can cause damage to the gastrointestinal tract, lack of induction of gastrointestinal motor activity development and luminal nutrients, and failure to release trophic enteric hormones. Mothers of ELBW or VLBW infants often have insufficient breast milk. The infants must therefore be fed breast milk fortified with multi-nutrients. However, the interesting fact is that mothers who give birth to premature infants have significantly higher protein in content in their breast milk than mothers who give birth to full-term infants. This is also true for nutrients like calcium, zinc, copper, sodium, and chlorine. ELBW infants fed on their own mother's fortified milk exhibited fewer infection-related events and shorter hospital stays than other preterm formula-fed infants. Dietary fat is necessary to be provided to premature infants with a desire to achieve a daily gain of about 3 grams of adipose tissue per kg of body weight. The smaller and more premature the infant, the greater the degree of vitamin E deficiency. Vitamin E is a fat-soluble vitamin, and as we learned earlier, the immaturity of the VLBW gut makes it difficult for the infant to handle and assimilate fats. Premature infants are born with a limited ability to assimilate exogenous iron. The risk of hemolysis can be reduced or avoided by avoiding iron supplementation in the early postnatal period, providing polyunsaturated fatty acids only at adequate levels, and ensuring that there is ample vitamin E to reduce lipid peroxidation. So, let us quickly recap and sum up the nutritional needs of the premature infants. Increased caloric density, increased protein intake for rapid growth, avoidance of hypersmaller feeds, reduced lactose loading, assimilable fat source, low iron intake, increased calcium and phosphorus levels for bone growth, increased sodium intake, increased vitamin E. All this can be provided by mother's milk, duly fortified as per the requirement of the individual infant. With that, we come to the end of today's topic. We hope it has been a good learning experience for all of you and will help you make informed decisions when it comes to nutrition for premature infants. Thank you.